Today we will be discussing on total hip replacement. The most important thing in total hip replacement for a success of total hip replacement is accurate placement of the acetabular as well as the femoral component positioning. Why this is important? This increases the stability and reduces the risk of the dislocation. It avoids impingement to get a good range of movement, stable gait, limb length, and to reduce cup wear, early loosening, and to reduce noise generation. This accurate placement of the component is very important. So what is ideal acetabular cup placement? It depends on the three factors mainly: depth or mediolateral positioning, height or superior inferior positioning, and angular placement or inclination and version. So depth of the cup, it contributes to global offset. So combined offset, it is a sum of acetabular offset plus the femoral offset. It determines the lever arm of the body weight to the abductors. And center of the hip joint should be matched with the previous pre-op condition. Second parameter is the depth of the cup. It is an excessive medialization of the cup has a high risk of reduced range of movement, bony impingement, and loss of medial bone. Excessive lateralization of the cup has a high risk of cup impingement, reduced coverage, and reduced bony contact, early loosening. So it also reduces the lever arm of the abductors. The third main component is the height of the cup. See, affects the gait. It also has a low back pain and instability of the hip. High center of rotation causes shortening of the abductors, raises the hip joint forces, and high chances of perceptive loosening and implant failure. With a low center of rotation, it has a early chances of revision. The angular positioning of the cup determines the range of movement, impingement, stability, and long-term survival of the acetabular component. What is a permissible inclination? So there is an inclination of a 45 degrees plus or minus 5 degrees. Antiversion should be around 10 degrees plus or minus 10 degrees. Inclination is 30 to 50 degree and antiversion of 5 degrees to 25 degree is considered as a safe zone by Levenwick and G and et al. So how to achieve this? So main thing is pre-op templating. You must have a pre-op planning. Intra-op, nowadays most of the joint replacement surgeon, they depend on the intra-op parameters rather than a pre-op templating, because there are few problems with the templating. So main consistent factors are intra-op. There is a patient positioning, external cup positioner, bony and soft tissue landmarks, and combined antiversion. We'll see one by one. So templating has a limited role nowadays. It should be practiced for implant size, center of rotation, cup positioning, depth, and angle. Various softwares are available nowadays for a pre-op templating. The patient positioning, majority of us do THRs in lateral position. Patient should lie straight in the dead lateral position with pelvis and shoulder should be in one plane. Patient should be fixed well in this position. External positioners, they have a limited roles, totally depend on the patient positioning. So the intra-op landmark, which are the most important structures and used by many or almost all joint replacement surgeon, is a positioning of the TAL. So TAL is a transverse acetabular ligament. So if the cup is parallel and just deep to it, so that is the ideal cup positioning. If it is too inside, that is medialized cup. If it is too out, you cannot see a TAL, that means your cup is there is a lateralization of the cup. Okay, and you can judge retroversion as well as antiversion with the position of the towel with the relation to the cup. Then the combined antiversion. So the combined antiversion is judged by a coplanar test, and it should be between 30 to 45 degrees. Combined antiversion of the femoral component as well as the combined antiversion of acetabular component should be between 30 to 40 degree. That is considered as the best position. Practically, how to do it? You must have a 360-degree exposure of acetabulum. Find the exact depth, concentric reaming. You can do trials and then the actual cup positioning. So 360-degree exposure of the acetabulum. You must see cotyloid fossa, teardrop, and a medial wall. Tal should be totally visible. Anterior and posterior wall and anterior posterior. Take a feel of a anterior and posterior column. These are the placement of the retractors. These are the zones which shows safe zone and dangerous zone or zones with the caution for placement of the retractors. In the reaming technique, remove the labrum, pulvinar and osteophytes, identify fat pad, cauterization of the obturator branch, increase depth with small reamer 30 to 40 till medial wall is seen, serial reaming, careful with the reference with the towel and till the reamer starts gripping the wall. Reaming technique, soft tissue should be constrained. Where it is soft tissue pushing, you must know. In an anterior approach, the soft tissue pushes inferiorly and posteriorly. So we have to push the ream inferiorly and posteriorly to avoid reaming of the anterior wall. Posterior approach, to keep pushing inferiorly and anteriorly to avoid reaming of the posterior wall. Keep checking after each ream. How do I know you are done? So usually are more than 80% of the punctate bleeding you must see. Reamers should grip the wall of the acetabulum and one size under ream depending on the bowl quality. The stable press fit cup, do not rely on screws. Flush anterior margin to avoid soft tissue impingement. Flush inferior margin to avoid high hip center and check for the stability of the cup. Now, the other part of this is the femur component. The femoral stem positioning, how and why. So, the entry should be lateralized entry. It should be neutral to 5 degrees of antiversion. Restoration of abductor function with neutral or slightly valgus stem positioning. Obtain near normal horizontal or a vertical offset. Achieve limb length and use of ideal femoral stem. So what is a horizontal and vertical offset? The figure is self-explanatory. It will show the horizontal and a vertical offset. Everybody knows it. The femoral neck cut should be good. Some system they give template for neck cut, but usually from around 1 centimeter from the lesser tuberosity is the ideal neck cut. So abductor muscles in the normal, it should be in stem should be the tip of the stem should be in the medullary canal. If it is touching the lateral cortex, the stem is in varus, and if it is touching the medial cortex, it is in valgus. So depending on the abductor muscles, tension changes. So it's a localization of the entry point. The entry point should be as lateral as possible with neutral to 5 degrees of antiversion. We must take it lesser trochanter as your guide. Lesser trochanter is usually as 5 to 10 degrees of a retroversion. So you must try to aim your stem at 5 degrees of antiversion. Then selection of the entry point, posterior lateral wall to piriformis fossa. is essential to avoid the varus positioning. You can use the modular box osteotome. Then femoral canal entry with blunt tip narrow canal finder in right direction to avoid the perforation of the cortex, especially in osteoporotic bone. Then there is a compactor. You have to compact the cancellous bone. Then serially you can go by broaching the compacting bone from 0, 1, 2 and till your exact press fitting point is achieved. The entry point should be posterolateral. Version should be 5 degrees of anti-version. Start with the smallest broach. Gradually size is increased till the rotation and the lateral longitudinal stability is achieved. So again the varus, neutral and valgus stem positioning. Leave last broach in place and use a calcar reamer to flatten out the calcar, and you can do the trials of the components. Okay. Use adequate size rotationally stable femur stem in a neutral position. Restoration of the horizontal and vertical offset. Restoration of the rotation of the center of the hip joint. So if you assess a post-op X-ray, the line joining two ASIs, line joining two greater trochanters, line joining to lesser trochanters should be parallel to each other. Thank you.